way that younger people are becoming less and less, and older people are becoming more and more. In India, this is not the issue because still demographic is very different. But because of this problem, specialities are becoming further specialized to manage elderly and geriatric patients. Okay, so the prevalence and importance: 1 in 2 postmenopausal women, they experience prolapse and or urinary incontinence. We do not know any other medical condition in the whole medicine where 50% of the female population can have a problem like that. This is the commonest scenario a woman can entail in the course of her life. So 1 in 2 is huge, and it is a higher burden in bedridden elderly. And the purpose of this presentation is to provide evidence-based strategies prioritizing patient-centered care and ethical consideration. Obviously, in addition to demographic population, there is also a new concept of euthanasia, which is becoming more and more advanced. So that is also a worrisome thing when people become so upset they would like to end their life. But of course, we don't allow that. In the UK, it's not legalized. Okay, so pelvic organ prolapse affects any compartment. It can be any compartment like anybody else: anterior, posterior, apical. And the risk factors are multiparity. But multiparity is usually not an issue in the UK, but the main problem in aging population is reduced estrogens, immobility, and sarcopenia. Sarcopenia means reduced muscle mass. So they can have any type of urinary incontinence, all we have been discussing, but the one we worry about is overflow incontinence and functional incontinence. Okay, so what happens there in elderly? The main thing we have been talking about repeatedly is the muscle mass deficiency. Every year after age 40, we lose 5% of our muscle mass. So pelvic floor muscles are also part of the same muscles as other parts of the body. So the muscles get even more weakened after age 75, and reduction in actual muscle mass affecting levator ani and other pelvic floor muscles as well. So connective tissue degeneration, nowadays a lot of young people, they take supplements in the form of collagen, because the concept is the collagen is so vital in maintenance of everything we do. Collagen loss and altered elastin. So elastin also gets changed. That's why elderly people could have a lot of wrinkles and also joint problems. Hormonal changes, estrogen deficiency, we all know, results in thinning of vaginal epithelium, reduced blood flow, weakening of urogenital tissues, and facial and ligamentous damage, especially pubocervical fascia, rectovaginal fascia, and it disrupts structural integrity of vaginal wall. That those were anatomical changes, but in addition to that, with passage of time, we have neurological decline, the main one being peripheral nerve dysfunction, and the top of the list is diabetes, because diabetes does affect peripheral nerve function, Parkinson, multiple sclerosis, and it is surprising how common these conditions are in Europe, particularly Parkinson's and multiple sclerosis. Detrusor overactivity and underactivity, as well as aging, also leads to decline in actual pelvic nerve fibers, reducing neuromuscular control over continence. So these were peripheral nerves, but in addition to that, we all know when we get aged, we have central nervous system impairment like stroke, dementia, spinal cord injuries, impaired bladder coordination, and diminished reflex pathways. For example, aging reduces sensitivity of bladder stretch receptors, causing incomplete emptying and overflow incontinence, as I mentioned earlier. So functional impairment, so chronic immobility, prolonged bed rest, particularly if people are in a nursing home, they are not able to mobilize alone because they need support and there is no one to support them. So prolonged bed rest exacerbates pelvic muscle atrophy, impaired venous return leading to venous congestion of pelvic tissue. Reduced abdominal muscle tone, again diminished ability to generate intra-abdominal pressure for effective voiding, so they can have like overflow incontinence. And in addition to that, detrusor muscle itself can get weak. So like in younger people, detrusor becomes hypertrophied. In older people, can become hypocontractile. So it doesn't contract. So most of the problems are backflow and a very large bladder with overflow incontinence. So talking about urinary tract specific pathophysiology, detrusor overactivity, detrusor muscle undergoes fibrosis and ischemia resulting in uncoordinated contractions. So there could be bizarre patterns of detrusor contractions, and urgency and frequency is extremely common. Bladder wall compliance, as there is loss of elasticity, so bladder becomes a bit more like plastic type of thing rather than elastic type of thing, and it leads to urgency and frequency. Sphincter dysfunction we all know because of peripheral nerve disease and previous prior pelvic surgeries. They also predispose to stress urinary incontinence. So the comorbidities which we are in particular concerned are COPD, which is extremely common. Chronic coughing increases intra-abdominal pressure. Obesity is a big issue, and constipation. Because of all the joint problems, they take all the painkillers which can result in further constipation. So what do we do? Each patient should be taken with holistic approach, with comprehensive history. We need to check their voiding habits, incontinence triggers, prolapse symptoms, and comorbidities. Physical examination, even if they don't report prolapse, we need to keep an eye and check for prolapse, do POP-Q staging. Vaginal atrophy should be addressed, and post-void residual urine should be checked with a bedside scanner. Diagnostic bladder diaries can be very difficult in very elderly and frail, but their carer can be asked about their voiding patterns. Urine analysis is a must, as we were discussing yesterday in recurrent UTI sections. Urine analysis is a must investigation, and functional assessment. So what can we do for them? Most of the time we will be focusing on conservative management in elderly, behavioral intervention like bladder retraining and timed voiding, because they may not have sensation of detrusor contractility or urge sensation. So we need to check that at least they pass urine every 4 hours. So that is a time frame which we would like their carer to take them to the toilet or provide them with a bedpan. 4 hours is an optimal time. Pelvic floor muscle training, again there are challenges in immobile patients, caregiver assistant programs, and lifestyle adjustment like avoid bladder irritants, which we discussed earlier, tea, coffee, hot chocolate, and fizzy drinks, and manage constipation. Use of pessaries in pelvic organ prolapse, that is a mainstay of treatment when patients are not willing to have surgery, and they support pelvic organ, reduce prolapse symptoms, they reduce edema on the dependent part of the prolapse, hence reducing likelihood of development of ulcers and friction bleeding, and may help with incontinence. Challenges are pessaries can be neglected. Recently, I saw a patient, she probably had a pessary inserted 12 years ago, but she has dementia, so she never mentioned to anyone. So when she started to have a lot of bleeding, then she was brought to hospital, and then a ring pessary with a lot of granulation tissues were found. So if there is any element of cognitive decline, we should avoid pessaries in elderly, because there is no one to remember that. Pharmacological intervention, this we discussed earlier, that why overactive bladder medications are important, but we need to know that contraindication in elderly, particularly cognitive impairment. So solifenacin is the commonest anticholinergic which is used in the UK, but long-term use, long-term means more than 1 year, is associated with cognitive impairment. Another problem with antimuscarinic is close angle glaucoma. So glaucoma has two types, open angle and close angle. So whenever we prescribe someone anticholinergic, we should ask for optician to check whether they have close angle glaucoma. If they have close angle glaucoma, we give them anticholinergic, they can lose their eye. So it's really important. Beta 3 agonist is a safer alternative if they don't have uncontrolled hypertension. So hypertension which is controlled with medication, which will be the case in most of the elderly, beta 3 agonists are not a contraindication. But if they have renal failure or compromised renal function, we never give 50 mg, we always give only 25 milligram in elderly. We talked about vaginal atrophy and UTI prophylaxis. Sometimes these elderly patients, whenever we do dipstick, there is always pus cells and there is always nitrites positive, because sometimes these bacteria will not go away whatever you do. Sometimes if they have bacteriuria, pyuria and symptoms, then we think about prophylaxis. But if there are no symptoms, there is no need. Symptoms mean fever and dysuria, lower abdominal pain, feeling malaise and unwell. The only problem here is because of elderly's compromised immune system, sometimes they do not mount a feverish response to an infection. So this is a problem, because then we can neglect them, not giving them antibiotic. But we need to check other vitals to find out, because sometimes they may be going into sepsis but without mounting a fever response. So whenever we consider low dose antibiotic for recurrent infection, usually our regime, as we were discussing before, is one antibiotic for 3 months, for example, trimethoprim 50 milligram bedtime, and then next 3 months nitrofurantoin 50 milligrams bedtime, and then cefalexin. So these are the three we can use in this manner for 9 months. But again, a word of caution about long-term antibiotic use, and each and every antibiotic has specific problems when they are used longer than 6 months. Catheterization strategies, we prefer self-catheters instead of indwelling Foley's catheter. But if there is retention, we can teach elderly self-catheters, but then manual dexterity is a problem, and sometimes they are not able to self-catheterize. So the options are urethral catheter or suprapubic catheter. But then hygiene and regular monitoring are essential. Sometimes they do end up having a suprapubic catheter or urethral catheter. So if there is severe prolapse or refractory incontinence unresponsive to conservative measures, then we consider surgery. And then it could be vaginal repair or colpoclysis for large prolapse. And then we need to optimize comorbidities and involve MDT. So we cannot operate on any patient in urogynecology unless we have had approval and discussed in MDT. It's not only elderly, each and every patient. So that is a must in UK practice if anyone is here preparing for MRCOG Part 3. Many candidates fail on this point. They do not mention MDT before surgery. Ethical concern, we need to involve patient and caregiver in decision making, and we need to check who has got power of attorney if they have got dementia. So we need to check power of attorney, that it is valid power of attorney, and then discuss these things with the patient. And prioritize comfort and dignity. And then it should be a team management with physiotherapist, geriatrician, continence nurses, and caregiver. So I just wanted to show these questionnaires, not related to this particular one, but all urogyne patients. So there are two types of questionnaires which each and every patient who is going for surgery, they fill up. So the first one is ICIQ FLUTS questionnaire, ICIQ female lower urinary tract symptoms questionnaire. So anybody who is having incontinence surgery like Bulkamid, Botox or sling, they fill in ICIQ FLUTS questionnaire pre-op and 3 months post-op. Anybody with prolapse, they fill up ICIQ vaginal symptom VS questionnaire, pre-op and 3 months post-op. So this is also important for trainees who are going for exams, because this is usually question, which questionnaire will you fill in for this particular patient. So again, we need to enter all the data of British Society of Urogynecology, and this is how we score and enter it on computer. So practical tips, assistance with the toilet, portable commodes, bedpans, or adaptive devices. I know in India we are far behind in these things, but I think this is something to think about. Provide bedpans, portable commodes beside the bed, and these things. And skincare, barrier cream, absorbent products to prevent dermatitis with frequent leaking, and education. So one of the tip, because not everybody can use a lot of estrogen cream, and if they have history of breast cancer, another thing which I commonly use for my elderly patient with skin dermatitis is extra virgin pure almond oil. So this is something you can, it is the best tip you can give to your patients, even younger people. So all of my patients, I tell them extra virgin sweet almond oil. Whenever they have a shower or wash themselves, they can apply in their groins and private areas, and that is the best one for the skin down below, instead of using other creams which have many other ingredients. So we need to train caregivers on catheter care, Pessary maintenance and signs of complication. We are nearly there. So emerging therapies, neuromodulation for OAB in frail population, as we discussed, like PTNS could be the best suitable option because it doesn't involve any medication. And improved pessary design, like incontinence dish pessary to prevent incontinence. We need high quality trials addressing conservative management in immobile elderly. So management should be patient tailored and MDT approach. Conservative management is the key and surgery is only for selected group. Focus on improving quality of life and caregiver support. So these are the references. These are all for exams, guidelines you all need to know. Okay, any questions about elderly or frail patients or any particular concerns you may have? In India, people usually don't live as long as abroad. So as I was mentioning previously that my oldest patient I operated on was 97. So, and she feels entitled that if she needs surgery, surgery should be provided. We should never say, oh, you are 97, we will not give you surgery. So everybody has right to choose, and I think this is something we need to consider in India as well. After 60, usually people are on bed here. So I think we need to change that. Okay, so shall we go straight to the next presentation? And then we can discuss. Okay, so this is an interesting one, but